Welcome back to the deep dive. Usually we take a topic and spin it around to see it from every angle, often for, the pure joy of learning. But today, today feels different. Today, the pressure is on. We are shifting gears into full-on coaching mode.
We certainly are. The stakes are significantly higher than just being interesting at a dinner party.
Exactly. Let's set the scene for the listener because I want everyone to feel the specific kind of anxiety I'm channeling right now. Picture this. I am a third-year resident. I am stressed, I am definitely over-caffeinated, and I am staring down the barrel of the MD anesthesiology exams, specifically the Gujarat University finals, though this applies to pretty much any high-stakes board exam. And you are the senior faculty. You are the mentor standing between me and, well, failure.
I am ready to play that role. And the topic on the table is arguably the single most critical diagnostic tool in our entire arsenal.
Yeah.
It's the absolute bread and butter of the ICU and the operating theater.
Arterial blood gas analysis.
ABG, yes.
And we aren't just skimming the surface here. We have a massive stack of sources today. We've got chapters from Miller, Morgan, and Mikhail, the ICU book by Marino, which is, it's practically the Bible for this.
It really is.
We've got Guyton's Physiology for the deep mechanics, and specifically for our exam context, the ARC and DNB question bank guides.
And the mission's very specific. I don't just want you to be able to glance at a printout and say, oh, the patient is acidotic.
Right.
Any first-year resident can do that. I need you to be able to construct a structured 20-mark long answer, handle the nuances of short notes, and survive the Viva station without getting grilled alive.
That is the goal. So let's simulate the exam environment. I'm sitting in the hall, I turn over the paper, and there it is. Question 1, 20 marks.
Yeah.
Discuss arterial blood gas analysis. Where do I even begin? Do I just start listing numbers?
Absolutely not. That is how you fail to get a distinction. You start with authority. You need a crisp academic definition. An ABG analysis is a diagnostic tool that provides immediate quantitative information on 3 specific physiological processes.
Okay, let me guess. Oxygen and acid.
Too simple. You need the 3 pillars: alveolar ventilation, acid-base balance, and oxygenation.
Alveolar ventilation.
If you miss alveolar ventilation, you have already lost the examiner's interest.
Right, because PASO2 is our direct window into how well the lungs are actually moving air.
Exactly. And immediately after defining it, you frame its relevance. Why do we care? In anesthesia and critical care, this is the gold standard. We use it to guide mechanical ventilation. We use it to assess therapeutic interventions like, did that fluid bolus actually fix the metabolic acidosis? And we use it to monitor the critically ill. It is the compass by which we sail the ship.
Okay, introduction is done. I've defined it. I've stated the importance. Now, structurally, for a 20-mark answer, I need to list the components. This feels like the easy part, but I have a feeling there are traps here. I've seen residents get yelled at for getting a normal range slightly wrong.
The trap is vagueness. In a Viva or a written exam, accuracy is what separates a pass from a distinction.
Okay.
We talk about the big 3 plus 3. You need to list all 6 key components with their precise normal ranges.
Big 3 plus 3. I like that. Let's run them down. The first of the big 3 is obviously pH.
Correct. The measure of acidity or alkalinity. The range is 7.35 to 7.45.
Is it true that 7.40 is the absolute normal? I've heard that.
Yes. 7.4 your anchor. In exam calculations, if you're given 7.39, treat it as being on the acidic side of normal. If it's 7.41, it's on the alkalotic side. Precision matters.
Got it. Okay, number 2 of the big 3, PACO2.
Partial pressure of arterial carbon dioxide.
Yeah.
The normal range is 35 to 45 millimole Hg. And remember, this is your direct index of alveolar ventilation.
Right.
It's inversely proportional to how much the patient is breathing.
We'll dig into that physiology in a second. Third one, PACO2.
Partial pressure of arterial oxygen. 80 to 100 millimole Hg on room air. But here's the nuance. It's age dependent. A 20-year-old should be near 100. An 80-year-old might be closer to 80. Don't call an 80-year-old hypoxic just because their PO2 is 82.
That's a good clinical pearl. Okay, those are the big 3. What are the plus 3?
These fill in the gaps. First, bicarbonate or ACO3-. This is your metabolic component.
And the range.
The range is 22 to 26 millimole or MBQL. You'll see both.
Okay. And then we have the base excess. I always find this one a bit abstract.
It's actually very practical. Base excess or base deficit tells you the amount of acid or base required to return the blood to a normal pH.
No. Right.
Assuming the CO2 is normal. It quantifies the metabolic problem purely, stripping away the respiratory noise. The normal range is -2 to +2 MEQL.
So it isolates the metabolic part of the problem.
Perfectly. And finally,
SO2.
SO2, the arterial oxygen saturation, should be 94% to 100%. If you list those 6 with those exact numbers, you've secured your baseline marks.
Okay, I've got the list. Now, usually, the next section of the exam answer is physiology. This is where I tend to get bogged down. I feel like I'm writing a textbook chapter. How deep do I need to go?
You need to show you understand the mechanism. This is the exam core. This is where you differentiate yourself from a machine that just spits out data. You need to connect the numbers to organ function.
So connecting PaCO2 to the lungs.
Precisely. You must state the relationship clearly. PaCO2 is inversely proportional to alveolar ventilation, VA.
Right, the formula.
The formula is PaCO2 is proportional to VCO2 divided by VA.
Okay, lay that out in plain English for me.
If you double your ventilation, if you breathe twice as much, you have your PaCO2.
Okay.
Conversely, if your ventilation drops by half, your PaCO2 doubles. It's a linear mechanical relationship. High CO2 means the lungs, isn't clearing the smoke.
Simple enough. Now, acid-base balance. This is the heavy lifting. I always struggle to explain the buffering systems concisely without writing a novel.
Think of it as a war. The body have a 3 lines of defense strategy against pH changes. If you write it this way in the examiner will love the structure.
Okay, line 1.
Chemical buffering. This
Yeah.
is the immediate response. It happens in seconds. The bicarbonate buffer system is the heavyweight champion here in the extracellular fluid.
Mm-hmm.
You have carbonic acid turning into H+ in bicarb. But don't forget the others. Hemoglobin, specifically the histidine residues, and plasma proteins also mop up acid.
So that's the rapid response team. Seconds.
Correct. But they get overwhelmed easily. That brings in line 2. Respiratory regulation. This takes minutes. If your brain senses acid, it drives the lungs to blow off CO2.
Because CO2 is essentially a volatile acid.
Exactly. Getting rid of CO2 raises the pH. It's powerful, but it can't fix everything. That leads to line 3, renal regulation.
The kidneys. The slow movers.
Slow but effective. This takes hours to days. The kidneys are the ultimate cleanup crew. They excrete fixed hydrogen ions, and crucially, they regenerate bicarbonate.
Okay, so for the exam, chemical in seconds, respiratory in minutes, renal in hours to days. That's a solid structure.
Perfect. Now we move to the heart of the matter, the interpretation. If you are handed an ABG slip in Aviva, do not just stare at it and guess metabolic acidosis. You must demonstrate a system.
The systematic stepwise approach.
Yes,
Yeah.
it's very high yield. And actually, before you even look at the pH, there is a step 0.
Step 0. I thought we started with pH.
Most people do.
Yeah.
But the ARC guide specifically mentions a validity check. Before you interpret, check if the numbers are even physically possible. Machines make errors. Samples get corrupted.
How do we check?
You use the modified Henderson equation. The concentration of hydrogen ions times the bicarbonate divided by the PaCO2 should equal 24.
Well, wow.
The formula is H+ times bicarb over PaCO2 equals 24. If the numbers on the printout don't fit that equation, throw it away. The machine is wrong.
That is a pro tip. I can see an examiner asking, are you sure these results are valid? And me just sweating. Okay, assuming the data is valid. Step 1.
Assess the pH. Is it acidemic less than 7.35 or alkalemic greater than 7.45? This tells you the primary direction of the disturbance.
Right.
Even if it's a mixed disorder, the pH usually points towards the primary culprit.
Okay. Step 2.
Identify the primary disorder. You look at the PaCO2 and the HCO3. We use the classic rule of thumb. Same direction as metabolic, opposite direction as respiratory.
I use that mnemonic, but explain the logic for the listener.
Sure. Look at the pH. Let's say it's low. Acidosis. Now look at the bicarb. If the bicarb is also low, both arrows are going down. Same direction.
That's metabolic acidosis.
Exactly. Now, if the pH is low, down arrow, but the PaCO2 is high up arrow, they are moving in opposite directions.
That's respiratory acidosis.
Same equals metabolic.
Yeah.
Opposite equals respiratory. It works every time.
It does.
Yeah.
Now, step 3, this is where the math anxiety kicks in for most residents. Assess compensation.
Right. Is the body trying to fix it?
Exactly. And is the compensation appropriate? Meaning, is the body doing enough? Or is there a second problem stopping it?
And this is where you need to know your formulas.
I dread the formulas. Which ones are absolutely non-negotiable for the exam?
For metabolic acidosis, you live and die by Winter's formula. Expected PaCO2 equals 1.5 times bicarb plus 8, plus or minus 2.
Okay, 1.5 times bicarb plus 8. Why is this one so important?
Because metabolic acidosis is the most common severe disturbance you'll see in the ICU sepsis, DKA, shock. You need to know if the patient's lungs are compensating correctly.
Right.
If you calculate the expected CO2 to be 30, but the patient's actual CO2 is 40, what does that tell you?
It tells me the CO2 is higher than it should be, so they aren't breathing enough. They're hypoventilating relative to their acidosis.
Exactly. They have a concomitant respiratory acidosis. They are tiring out. That is a warning sign of impending respiratory failure. You might need to intubate. If you didn't do the formula, you'd look at a CO2 of 40 and think, oh, that's normal. But for that patient, 40 is deadly.
That makes sense. Normal is relative. What about respiratory disorders?
For respiratory disorders, the kidney compensates. But remember, kidneys are slow. So you have to distinguish between acute, which is minutes, and chronic, which is days. The rules are different.
This is the 1 for 10 and 4 for 10 rule.
Yes. Let's take respiratory acidosis high CO2. In an acute case like a heroin overdose that happened an hour ago, for every 10 mmHg rise in CO2, the bicarb only goes up by 1.
Just 1.
The kidneys haven't had time to work yet. But in a chronic case like a COPD patient who's been retaining CO2 for years, for every 10 mmHg rise in CO2, the bicarb goes up by 4.
So if I see a patient with a CO2 of 80, which is very high, but their pH is almost normal, it's because their bicarb is through the roof.
Exactly. They are a chronic retainer. If you see a CO2 of 80 and the bicarb is normal, that patient is acutely dying.
That's a huge difference.
And the same logic applies to respiratory alkalosis, just in the other direction. Acute, bicarb drops 2 for every 10 mmHg drop in CO2. Chronic, bicarb drops 5 for every 10.
So the sequence to memorize is 1, 4, 2, 5. Resp acidosis, 1. Acute, 4 chronic. Resp alkalosis, 2 acute, 5 chronic.
Correct. Write that little table in the corner of your exam paper immediately. It saves brain power later.
Good tip. Okay, formula is locked in. Moving to step 4, this is my favorite exam topic, the anion gap.
An absolute exam favorite. You calculate the anion gap for every metabolic acidosis. It classifies the disease.
And the definition.
The difference between measured cations and measured anions. The formula is sodium minus the sum of chloride and bicarb.
And the normal range. The books vary on this.
Stick to the ICU book. Normal range is 8 to 12 MEQL. If the gap is higher than 12, you have a high anion gap metabolic acidosis, HAGMA.
And this is where we trot out the MUDPILES mnemonic.
Yes, it's classic for a reason. Methanol, uremia, DKA, paraldehyde, isoniazid or iron, lactic acidosis, ethylene glycol, salicylates.
For cold tea. Right, the modern one.
Cold tea is good too.
Yeah.
Ketones, uremia, lactate, toxins. Easier to remember in a crisis.
And if the gap is normal.
That's normal anion gap metabolic acidosis. AGMA. Also called hyperchloremic acidosis. Think about the formula. If bicarb goes down but the gap stays normal, chloride must have gone up to balance the charge.
Right, something has to fill the space.
And this is usually due to losing bicarbonate from the butt diarrhea or the kidney's renal tubular acidosis.
Yeah.
Or, and this is crucial for us, giving too much normal saline.
Right, the abnormal saline acidosis. Now, wait. I recall a very high-yield warning in our notes about albumin here, the albumin trap.
Yes. This separates the residents from the consultants. Albumin is a major unmeasured anion. It makes up a big chunk of that normal gap.
Okay.
But what happens in the ICU? Patients are malnourished, septic, liver failure. Their albumin drops.
Right, so what does that do?
If a patient has hypoalbuminemia, their normal baseline anion gap is lower.
Give me the correction factor.
For every 1 gram per deciliter drop in albumin, the normal anion gap drops by 2.5.
Okay, let's do an example.
Let's do the math. Normal albumin is 4.0. Normal gap is 12. If your patient has an albumin of 2.0, that's a drop of 2 grams. Their expected normal gap drops by 5, so their baseline gap is 7, not 12.
So if I calculate a gap of 12 for this patient?
You might say, oh, normal gap must be diarrhea. But for them, 12 is high. It's actually a high anion gap acidosis.
I would have missed it completely.
You would miss a lactic acidosis or early DKA if you don't correct for albumin.
That is a crucial clinical pearl. I can see that being a Viva trap. Is the gap normal? And the answer is, depends on the albumin.
Exactly. Always check the albumin.
Okay. Step 5 is checking for mixed disorders. We touched on this with Winter's formula.
Yes, but there is one more advanced tool called the delta gap, or delta ratio. It compares the change in anion gap to the change in bicarbonate.
Delta Ag over delta HCO3.
Right. Basically, the broad concept is this. If the anion gap goes up by 10 because of some unmeasured acid, the bicarb should be buffered and drop by about 10. The ratio should be 1 to 1.
And if it's not?
If the ratio is very low, say less than 0.4, it implies you have a normal anion gap acidosis hanging around too.
Well,
But the really interesting one is if the ratio is greater than 2.
What does that mean?
It means the bicarb hasn't dropped as much as it should have. Why? Because there is a pre-existing metabolic alkalosis propping it up.
Ah, a hidden disorder.
Classic scenario. A DKA patient who is also vomiting. The DKA gives them a high GAB acidosis. The vomiting gives them a metabolic alkalosis. The bicarb looks weirdly normal. The delta ratio reveals the hidden alkalosis.
That sounds like a gold medal answer. And finally, step 6.
Clinical correlation. Look at the patient. Do the numbers match the history? If the ABG shows metabolic alkalosis, is the patient vomiting? If it shows respiratory acidosis, have they been given opioids? Never interpret in a vacuum.
Treat the patient, not the graph.
Exactly.
Okay, that's the interpretation framework. Step 0 to step 6. Let's briefly zoom out and look at oxygenation. We can't ignore the O in ABG.
Correct. Hypoxemia is generally defined as PO2 less than 60 millimole Hg. But again, context. In the ICU, we look at the PO ratio.
KO2 divided by FiO2.
Right. Normal is greater than 300 or even greater than 400. This is the cornerstone of the Berlin definition for ARDS. If the PF ratio is less than 300, you have mild ARDS. Less than 100 is severe.
It tells you how efficient the lung is.
Exactly.
Yeah.
How efficient it is at transferring oxygen relative to how much oxygen you're shoving in.
And the A gradient, I always get asked about this.
The alveolar arterial gradient tells you why the patient is hypoxic. The formula is big AO2 minus little AO2.
So alveolar versus arterial.
Correct. If the gradient is normal, the lungs are working fine. The patient is just hypoventilating. The high CO2 is displacing O2 or they're at high altitude. If the gradient's widened or high, there's a lung problem.
I need a structured list for the causes of hypoxemia question. I feel like that comes up all the time.
There are strictly 4 physiological causes,
Oh.
plus low inspired oxygen. 1, hypoventilation. The lung works, but the pump is slow. Normal A gradient.
Okay.
2, VQ mismatch. Ventilation perfusion mismatch. This is the most common cause. Pneumonia, PE, COPD. Key feature. It responds to oxygen. 3 is shunt. Blood bypasses the alveoli completely. Atelectasis, severe ARDS, cardiac shunt. Key feature. It does not respond significantly to oxygen.
And the last one.
Diffusion defect, think fibrosis. The membrane is too thick for oxygen to cross properly.
Differentiating shunt from VQ mismatch using the response to oxygen. That's a Viva favorite.
It is. Why didn't the PO2 go up when you gave 100% O2? Answer.
It's a shunt, sir.
Let's bring this to life with some common clinical scenarios. How does this look in practice? Scenario 1, the COPD patient comes into the ER.
Classic chronic respiratory acidosis. You expect a high PaCO2, maybe 50 or 60, but the pH will be near normal, maybe 7.35 to 7.38, because the kidneys have retained bicarb.
Right, compensation.
So bicarb will be high, maybe 30 or 35. This is compensated respiratory acidosis. And a warning, if you put this patient on high-flow oxygen and knock out their hypoxic drive, their CO2 might spike even further.
Okay, scenario 2, diabetic ketoacidosis, DKA. INE gap metabolic acidosis. pH is low, bicarb is very low, sometimes in the single digits. PaCO2 should be low because the patient's hyperventilating, that Kussmaul breathing, to compensate.
And the trap.
The trap is if the PaCO2 is normal, say 40, in a severe DKA patient, be afraid. It means they are tiring out, they have a superimposed respiratory acidosis, they are about to crash.
Wow. Okay, scenario 3. An infant with pyloric stenosis.
They're vomiting stomach acid, so they lose hydrogen and chloride. The result is a metabolic alkalosis, high pH, high bicarb, and usually hypokalemia. It's a hypokalemic metabolic alkalosis.
Let's talk about pitfalls. We mentioned the albumin trap. What else trips people up?
Oh, sampling errors are huge. You can interpret the numbers perfectly, but if the sample is trash, your treatment is wrong.
Like what?
Number 1, air bubbles. If you leave an air bubble in the syringe, the gas equilibrates.
Yeah.
Room air has a PO2 of 150 and a PCO2 of basically 0. So an air bubble falsely raises PO2 and lowers PaCO2.
Okay, no bubbles. What else?
Heparin. Liquid heparin is acidic and it dilutes the sample. If you use too much, it lowers the bicarbonate and PaCO2.
I see.
Venous admixture, hitting the vein instead of the artery. The blood looks dark, PaCO2 will be low, in the 40s, and PaCO2 will be higher than expected.
And what about time, if the sample sits around?
Big problem. Blood is living tissue. White blood cells consume oxygen. If you leave the sample sitting on the counter for 30 minutes without ice, the PaCO2 drops and CO2 rises.
So run the sample immediately is the takeaway.
Or keep it on ice. But speed is best.
Before we wrap up with the exam structure, tell me about the Stewart approach. I see it in the advanced textbooks. Do I need to know it?
For a pass? No. For a gold medal? Yes.
Okay, give me the gold medal version.
The traditional method, Henderson-Hasselbalch, focuses on bicarb and CO2. The Stewart approach, or the physicochemical approach, says that bicarb is just a dependent variable. It doesn't drive the pH, it just reflects it.
So what does drive it?
Stewart says pH is determined by 3 independent variables. 1, the strong ion difference, or SID. That's the difference between strong cations like sodium and strong anions like chloride.
Okay.
2 is ATOT, the total weak acids, which is mostly albumin and phosphate. And 3 is the PaCO2.
How do I use this in Aviva?
You use it to explain why saline causes acidosis. Saline has high chloride. Increasing chloride decreases the strong ion difference. A decreased SID leads to acidosis. It sounds very sophisticated.
I'll keep that in my back pocket. Finally, let's talk presentation. I'm writing that 20-mark answer. How do I make it look good?
Visuals win marks. Don't just write blocks of text. First, a flow chart. Draw a decision tree. Start with pH, branch to acidosis alkalosis, then branch to metabolic respiratory.
Oh yeah, visual guide.
Exactly. Second, a Davenport diagram. If you can sketch the pH versus HCO3 curve showing the respiratory and metabolic lines, you look like a scholar. It shows you understand the relationship between acute and chronic changes.
What else?
Tables. Draw the acute versus chronic compensation table we discussed. It's clean. It's easy for the examiner to see, the numbers.
And the conclusion. How do I wrap it all up?
Your conclusion should reiterate that ABG is a point-of-care test, but must be integrated with the clinical picture. Then summarize your steps.
The whole sequence.
The whole sequence. Validity check, then pH, then primary disorder, compensation, anion gap corrected for albumin, delta ratio, and finally, clinical context. And with the tagline, we treat the patient, not the numbers.
Treat the patient, not the numbers. I feel like I can actually tackle this question now. It's not just a soup of numbers anymore. It's a logical story.
That's the key. It's physiology in action. Just follow the steps, watch out for the albumin, and don't panic. You'll do great on the Gujarat University exams.
To our listeners, good luck with your studies. And here is a challenge for you. Next time you are on rounds, calculate the anion gap, but correct it for albumin. See if it changes your diagnosis. You might catch something everyone else missed.
That's where the real learning happens.
Thanks for listening. We'll catch you on the next deep dive.